up we have Dr. Fahad Razak, who will be speaking about clinical data infrastructure in Canada, asking, are we ready for the next pandemic? Dr. Razak is an engineer, an internist, and an epidemiologist with specialization in observational methods and big data. He is the inaugural provincial lead for quality improvement in general internal medicine at Ontario Health. And he also co-leads the General Medicine Inpatient Initiative, which is also known as Gemini, which is a big data network across hospitals that extracts data generated as part of routine medical care and uses that data for research and quality improvement. So welcome, Dr. Razak.
Hi, it's great to be with you today. Thanks for the opportunity to speak to your audience, and what a delight to follow Jeffrey Simpson, who is a hero of mine and someone who I've read for many years.
Well, I'll hand it over to you.
Okay, perfect. Thanks again for the opportunity. I'm going to talk today about our clinical data environment and where the opportunities are for health research and where we need to go, looking at some of the best examples in the world. I have no conflict of interest to declare other than being an employee of Ontario Health. So the three areas we're going to talk about today is first describe data and research infrastructure, and specifically look to the best example globally, which is the United Kingdom, which is the unparalleled leader in developing therapeutics for COVID-19. As a practicing internist and someone who does a lot of care for patients with COVID, really the two medications, and especially the first, which is steroids, that have proven to be beneficial, were discovered, or the leading research came out of the United Kingdom. And the question is why, and what can we learn from that? The second and related topic is, why are there challenges currently in performing this kind of embedded research in Canada? And I'm going to talk about this term of embedded research. And finally, to discuss factors that I think could make Canada a leader. We have certain factors already in place that would make us the envy of the world. It's just about harnessing them. So first, this topic of embedded research. I just want to make sure we're all using kind of the same concept here. And it's the idea that the people who are doing the research are embedded in the organizations, in the institutions where the clinical care is being delivered. So using myself as an example, I'm a researcher. I'm also an internist at St. Michael's Hospital, where I provide patient care. You want those two relationships to be as close as possible and to have people who are bridging those two areas. It means that research becomes culturally part of the delivery of clinical care, and this is where we can learn from the UK about a better model for how this can be done. It also means that the people who are delivering care are informing the questions which are being asked. So there's this bi-directional relationship. Okay, so with that introduction to the concept of embedded clinical research, first looking to the United Kingdom, and as I mentioned, this is really the global leader in how this can be done. So this was a joyous tweet from Martin Landry, who's a professor in the United Kingdom at Oxford, earlier this week, trumpeting the 1-year anniversary of the recovery trial. So the recovery trial is the most famous trial to look at therapeutics for COVID-19. It's why we know that we can treat people with dexamethasone. It's provided the largest sample for the next treatment that's found to be beneficial, called tocilizumab. In this 1 year, remarkably, the Recovery Network has studied 10 drugs. They've come to conclusive answers to show that 2 will save people's lives when they have COVID-19. 4, importantly, will not, and that includes drugs that were highly touted early in the pandemic, examples like hydroxychloroquine or azithromycin, things promoted by alternative media, things promoted by certain politicians globally. This is a study that definitively showed those medications were not beneficial. And the final point I think is important. The reason we do trials is often it's not clear going in what is beneficial and what isn't. So often the results are against people's prior beliefs. This is a screen grab of the most famous result, dexamethasone, published in the New England Journal by the Recovery Collaborative. And remarkably, within the United Kingdom, they have now recruited nearly 40,000 patients as of this week across 180 healthcare institutions to help answer important questions about COVID-19 care. So how did this amazing enterprise start? So February 28th, so just over a year ago, Martin Landry sent a message to Jeremy Farrar, who is the director of the Wellcome Trust, one of the big healthcare funding organizations in the United Kingdom. And he said, is anyone planning to do a randomized trial on COVID-19? So that was the question that Martin Landry asked. And he specifically said, because if we don't, then lots of drugs will get thrown at a lot of patients, and we will be none the wiser about whether any of them work or don't, or if they are even causing harm. So that was the starting point. Now, what happened? So February 28th, this email goes from Landry to Farr. Farr then points out that there's another investigator, Peter Hornby, who could be a good collaborator for Landry on this topic. From February 28th to March 10th, they then develop a protocol for how the research should be done. Remarkably, just 9 days later from the protocol being completed, there is already the legal improvements, the REB approval, and the first patient is recruited. And by May 14th, over 10,000 patients have now entered this study. And by June 22nd, there's a published preprint which changed clinical practice globally, showing that dexamethasone should be used for our critically ill patients with COVID-19. This is now our standard of care in Canada and across the globe. And just again, to highlight the remarkable pace of this, just 9 days from a protocol to recruitment of a patient, and less than 3 months from that protocol being approved to 10,000 patients being recruited. Now, I want to start with an important counterexample of how research was done largely across the globe and unfortunately here in Canada as well. And this is an analysis that was published earlier this year of the first 1,200 trials that were registered at clinicaltrials.gov looking at COVID care. These are bad statistics. So 25% of all trials really poured into this question around hydroxychloroquine. So without coordination, they chose a medication that a lot of early media was promoting, and they poured all their resources into that question, ignoring a lot of other beneficial therapeutics. And importantly, hydroxychloroquine has now conclusively been shown to be not effective. 40% of them were so small that they had less than 100 patients. And again, pointing back to recovery, you need many thousands of patients to answer important clinical questions. Fragmenting your research into many smaller trials just dilutes the research enterprise. Finally, a lot of these trials never got off the ground. They pulled in resources, they pulled in infrastructure, but many months after being funded, 40% of them had not begun to enroll any patients. So going back to recovery, what are the advantages and what can we learn in Canada? The first is speed. So again, I said 9 days from a protocol to the first patient being recruited. That means importantly that this study was in place in time for the first wave. So those many thousands of patients who entered recovery, that happened because the study was ready to pull them into research right away. The results are important. So when you get research done quickly, this estimate was just published in Nature Communications that probably more than 600,000 lives saved globally because of the results of the recovery trial, because we know this incredibly low-cost steroid medication can have a dramatic effect on survival in COVID patients. Second important takeaway, the streamlined approval process through a centralized REB and the legal agreements, the data sharing agreements. So again, the process of creating these agreements can be incredibly cumbersome and take many, many months. I've had to do many of these myself. They were able to create a central repository and location in the United Kingdom that would take care of approving these processes across the entire network rather than each individual hospital or research institution having to do it on its own. The third major area we can learn from recovery is the coordinating element of the central government in choosing promising research studies and pulling all the resources into these research studies. So this was a letter sent by the directors of the National Health Service, the NHS, in the United Kingdom to every hospital and health institution in the United Kingdom. And they said, we are, and I've highlighted here the key words, we are writing to ask that every effort is made to enroll COVID-19 patients into national priority trials. And these are trials across multiple sectors. We have chosen 3 trials, and we say that these are the 3 most important trials. We want you to put your patients into these trials to help establish the large sample sizes needed, to help get the pace needed to get the research results fast enough to improve patient care. And you'll see that recovery is one of these trials. Obviously, there's nothing parallel like this in Canada. Other advantages, the NHS and the National Institute of Health Research United Kingdom had invested in creating infrastructure within hospitals and healthcare institutions for over a decade. And that meant that a large number of hospitals could quickly come on board to answer these questions. Again, there is no parallel in Canada. So just in the dexamethasone part of recovery, 176 hospitals and healthcare institutions participated. That is an enormous number. And the estimate is that 1 in 6 of all hospitalized patients in the United Kingdom entered the recovery trial. Again, a remarkable number. Final important point is that in Canada, we keep the approval process of recruiting patients separate from those who deliver clinical care, the clinicians. Importantly, in the United Kingdom, they said, because we think research and clinical care are embedded together, those clinicians could recruit patients directly. What about gathering outcomes? So in the United Kingdom, they have sophisticated electronic health repositories, sort of like we do in Canada, but importantly, they say that these clinical repositories, these are the electronic health records that every hospital has or that are in primary care. The data from those can be used in an improved manner for research. So that data is being generated for clinical care. It's the lab test that I send or the x-ray that I send, but you can take that information and use it for research as well. Importantly, we can't do that in Canada currently. A trial platform. So Recovery was a platform, not just a single clinical trials. And that meant that the infrastructure that was put in place for the Recovery trial could be used to answer questions, not just the dexamethasone question. And here are 6 other medications that were tested, as I mentioned, all with very large sample sizes, all tested by Recovery in quick sequence. So they were able to answer questions now in a year about 6 important medications for COVID treatment. And then finally, political will. So this was a letter that was sent out again by the directors of the National Health Service, again spread throughout the entire network. This letter went out and it said, any treatment given for coronavirus other than general supportive care should currently be part of a trial where that is possible. So importantly, they were saying, as you are treating patients, we encourage you, strongly encourage you, to put those patients into trials. It's the only way that we can definitively find out whether these treatments that we don't know for a disease that didn't exist just a year ago, how do we know that these treatments will work? We need to study them. We need to put our patients into trials. So what are some of the challenges in performing this kind of embedded research in Canada? I mentioned a lot of it as I went through the advantages of the United Kingdom, but I'll just kind of briefly summarize again here. And I would say a really fantastic article about this topic was just published in CMAG at the end of 2020. I've provided a reference here in the bottom right corner. So 3 main areas outlined in this article, and I think they'll really hit home when you see the example of Recovery and what exists in Canada currently. First, there's no centrally supported infrastructure within Canadian healthcare institutions for this kind of research. And that means that each time you want to do a new randomized trial, you're often creating new labor. You're using new labor-intensive structures, the investment in people, the investment in data structures. That has to be replicated each time. It's expensive, it can be redundant, and often many of our smaller sites just can't get that infrastructure built quickly enough to answer a trial question. And that means Canadians who are sick from a condition, COVID-19, they may not even be at a center that can enroll them into a research study because that infrastructure is not already there. So this again is that 10-year window that the United Kingdom was slowly building up this capacity. The second, and this is culturally really important, and I think Jeff Simpson mentioned this as well, which is that there is a culture that has to be built up around research. And in our clinical environment, and I can say this as a clinician, research and the idea of research is not part and parcel of what we do every day. Research is really considered to be important, but separate in some ways from the delivery of care. And that's an important cultural mindset that has to be changed. I would say something that's been achieved in the United Kingdom and something that we can learn from. And then finally, research efforts are fragmented. So I highlighted those letters from the directors of the National Health Service in the United Kingdom. They told researchers that they needed to work together. They chose the priority studies and they routed patients toward those priority studies. Contrast that again to what happened globally and unfortunately what has happened in Canada in many circumstances. Many small studies, none of them get to the finish line. You never get that conclusive answer that you need. I'll stop on what I hope is an optimistic tone, which is that, in fact, Canada is a leader in many parts of randomized clinical trial science. That's largely in the international and multi-institutional setting, and I think we can harness those advantages to make clinical research better in Canada to study our own patients. So the first reason, and this is really important to realize, we have some of the best trialists and scientists in the world. The concept of large simple trials, this is what Martin Landry cited as his inspiring paper. That paper was written by Salim Youssef, the most cited clinical trialist in the world. He's at McMaster University. He's Canadian. And a lot of the work that's being done internationally across these huge trial networks is being driven by Canadians. Second, even though Canada only has 0.5% of the world's population and we're approximately 10th by GDP, we are the 3rd largest producer of impactful clinical trials research in the world, behind only the United Kingdom and the United States. That is remarkable, and again, it attests to the talent and the talent within the Canadian system. The question is, can you turn that internally also to study the Canadian population? And that's what the UK has really shown. But clearly the talent is already here. This is a network diagram showing of the most impactful clinical trials research done globally, where each country sits. And again, you can see Canada here, centrally, the third, after only the United States and the United Kingdom. What are some other advantages we have? Well, we already have large administrative data sets that can be used for research. Important examples that are currently being used include things like HiHi or the Institute for Clinical Evaluative Sciences, ICES. But there are other data repositories like the eHealth Ontario data streams. These are remarkably complex data streams that are being generated for clinical care. We are currently not using them for research. The United Kingdom has shown that they can be used safely. We should do the same here. And then I'll stop on a final note to say that we have some certain advantages in our population which are enviable and which will make countries around the world envious. Importantly, we have a multi-ethnic population. That means that research here is widely translatable. Contrast that to relatively homogeneous European countries that don't have that trait. Secondly, we have a single payer system, and that means that we essentially capture the majority of our population to do research on. Contrast that to the United States, where they have this private balkanized system where every hospital is part of a private network. You don't get that expansive spread or population coverage. So in conclusion, we can look to the United Kingdom as a best case scenario for what can be achieved. This is doable. We don't have to think about it in theoretical terms. The current Canadian clinical research environment is not there, and doing embedded clinical research is at times quite difficult. But we have certain advantages in place that could make us a global leader in this kind of work. And here's some of the papers that I cited in today's presentation. Would love to take any questions.
Well, thank you so much, Fahad, for answering our question, are we ready for the next pandemic? And I guess that's my sort of first question to you. You mentioned a lot of the assets and the infrastructure that we do have here, but that we might not quite be ready to emulate what happened with the recovery trial in the UK. So on a big picture thinking, blue sky thinking, what do you think it's going to take?
It's not a fast solution. So if you look to the example of the United Kingdom, the pivotal work to shift their system towards the infrastructure that was required for recovery started 15 years ago. And it's been slowly built and developed and nurtured over those 15 years. And then when a crisis like this pandemic hit, it instantly could be redirected and turned towards that problem. But we don't have to figure out what that infrastructure looks like. Like the United Kingdom, when they built it, there wasn't another global example of what that could look like. We now have that example. You don't have to recreate the policy or the strategies that are needed. We can learn directly from the United Kingdom. And then, as I mentioned, I think we have certain crucial advantages. We have world-leading scientific talent. We have a population that's captured. It's highly multi-ethnic, which means that the science is really valuable. So I don't think 15 years, but if that next pandemic happened next year, we again would not be ready. Certain actionable steps, though, can be taken right away. And I would say the most important and the one that doesn't require a lot of resources is coordinating research. So to say that you can't have this balkanized system where hundreds of researchers are choosing hundreds of different questions, each one of them doing relatively small sample size research that doesn't get to the finish line, pulling all of those researchers together the way the United Kingdom did, I think is really important. The second is the political will and the messaging to say that research and clinical care are the same. As you're caring for patients, you should be trying to pull them into research for these questions where we really don't know what the right answer is.
Mm-hmm. I think we have time just for one more question, and it touches on what you just said. So clinical trials are currently not integrated into the healthcare system, but what can we do to make that happen, or what can the government do to make that happen?
Yeah, so I think I mentioned a few of those, which is that it's the cultural shift. So that, importantly, this cannot be led just by health researchers. It has to come from government. It has to come from policymakers to say that this is a priority. When we are caring for patients, we're also learning how to best care for patients. The second important thing is that coordinating element, as I mentioned. And the third is that we have sophisticated data systems already in place. The Canadian taxpayer, the Ontario taxpayer has paid for those systems. Let's use that data also for research to help improve the care that we are delivering. Right now, a lot of that extremely valuable data is not accessible. but it could be, and the structure around it has already been created. And the UK example tells us that it can be used safely, respecting privacy and other considerations.
Well, thank you so much for your time with questions, for your presentation, for all the research that you put into that, and for showing us some pretty astounding data coming out of the recovery trial.